We are not live yet as of right now, just as a,
Okay.
we're just having a little video hiccup.
Good morning, everybody. It's a pleasure to welcome you to the 5th episode of our COVID-19 Game Changers series. My name is Leslie Nelson Bernier, and I have the privilege of serving as president of the UNC Health Foundation. And I feel like I say this on every Game Changers, but I'll say it again today. You're definitely in for a real treat. We have several presentations for you today. You'll hear from Dr. Wesley Burks, Dr. Michael Erthe, Dr. Crystal Sine, and Randy Towns. And I'm going to start just by turning things over to Dr. Burks to get us started. But I want to just make one quick mention of making sure that you use the chat function, question and answer. Please feel free to ask questions along the way, and we'll try to answer them as best as we can. Dr. Burks, I'll turn it over to you.
So thank you, Leslie, and thank you all for taking the time to join us today. I'm excited to be back with you and really excited to be joined by three outstanding colleagues, Crystal Sine, Michael Erthe, and Randy Towns. These are, as you'll come to see in the next few minutes, three incredible individuals who are helping and shaping how we can promote and make sure that we have health equity across the state of North Carolina. But before they get started, I want to update you just a little bit on some of the COVID statistics that we've talked about in our previous times together. So right now we have about 140 patients currently in our system hospitals. So that's all across the state. It's down from a high in the 190s that we talked about, but really is only slightly different from the last time we had this event. We have over 2,800 cumulative hospitalizations across the system, and the average age, again, is in the mid-50s. We've now done over 135,000 COVID-19 tests, and it's just under an 8% positivity rate for our system as a whole. We've had more than 2,500 discharges and 300 deaths. And again, as we talked before, that average age is in the mid-60s. But before you hear from our guests directly, I want to take a moment to thank each of them for the work that they're doing that really is so important to the health of people all across our state. Well, COVID-19 has impacted all of us in different ways. We continue to see that the underserved communities have a much higher burden than most of the rest of us during this pandemic. These three healthcare providers that you'll hear from today have committed literally their lives to creating a world where this isn't the case. one where our most vulnerable neighbors are not forced to feel the outsized impact from a public health crisis like we do now. I'm really, truly, personally grateful for the work that they're doing, and am encouraged by highlighting it today, and want to support them and the others that work here the best way that we can. And I'm thankful for their leadership. For each of the Game Changer events that we've had, we started the discussion with a question for our guest, and I'll start with Crystal, just to reflect a little bit personally how you're doing now in this 6th month of the pandemic. Crystal?
Thank you, Dr. Burks. It has been a whirlwind, to say the least. But I must say, when I really think back over the past 6 months and everything that's happened, there are a mix of emotions. Certainly just incredibly sad and troubled by the number of people and families who have suffered, and all of those numbers and thousands of people that we hear about. That's a life, and that's a family, and that's a story. So that's been incredibly hard. But I have also appreciated the fact that I am growing in this season and really taking this as an opportunity to just be content in whatever state and season I find myself in. So I am trying to really capitalize on the blessings that have come through this pandemic, in terms of being able to really slow down the pace a little bit and connect with family and friends in new and different ways. So overall, I'm blessed. Thank you for asking.
Yeah, Crystal and I have talked, and I'm just thankful for her sharing those thoughts, and just how much it has deeply affected her and her family. So Randy, just a few reflections that you might have.
Yes, so thanks, Dr. Brooks. I think similar to Crystal, I have a lot of mixed emotions about the last 6 months. I'll say early on in the pandemic, my father actually had COVID. So very early on, it was a very emotional, he was one of the first cases, and he lives in Texas. So being far away and having to talk to him on the phone, he had to go to the hospital by himself. His wife was told to sit outside. He knows not a lot about healthcare. So before starting the mobile testing project, I had personally dealt with how different healthcare had been, and what it really felt like to be dealing with a close family member who had COVID, which really brought a lot of passion for the mobile project when it came about. So then changing from a family member to now a deliverer of healthcare services, and being on the front lines of people who are really afraid, it was extremely empowering to be able to offer them help when they really needed it, but also I just felt really helpless most times, because they needed a lot of needs. So now, later in the pandemic, where not as many people are coming to get testing, a lot of people are now afraid about their children have to go to school, or their children have to go to daycare, or they now are being asked to go back to work, and trying to help them figure out what to do now. But I'm not a medical professional. I'm an administrative assistant. So a lot of it is normally just listening and providing just a friend to listen, I think. So it's been an interesting journey. I'm very appreciative for the opportunity. But yeah, COVID it's been an interesting 6 months.
So thank you, Randy. So Michael.
So thanks for sharing that, Randy and Dr. Sine. And I would say that I feel similar mixed emotions. So in February and March, I was in Zambia, and I was working with colleagues there in the Ministry of Health to kind of formulate national guidelines for the COVID-19 response. And we all had a wealth of previous experience with infectious diseases, battling things like HIV and TB. And we struggled with how we would respond at a national scale, imagine worst case scenario when we had so few resources. And then in the middle of March, I returned to the US, imagining that things could be better because we had more resources, and ultimately just feeling sad and frustrated and devastated by just the human toll that the epidemic took in the US, and how challenging it was to mobilize a similar response that I felt like we could do in Zambia because we had political will and imagination. But I think since that time, really what has kept me going is sort of being inspired by people like Dr. Sine and Randy. Actually, Randy and I worked in Hillsborough testing together, and there's countless other colleagues like that within the healthcare system. And I think, one of the most cathartic experiences was being in ICU with a number of other attendings, and it was the first time in a while where we were just all attendings, together, taking care of patients, and it was like an informal support group. And sort of that was in April, and I think every day since then, I've just been really getting inspired by people that you'll hear from on today's call and my colleagues.
So, Michael, thank you, and thank each of you for talking a little bit about the effect that it's had on you personally and your family. So as we begin, Michael was going to talk about just big picture coronavirus and where we are and how things are going. So Michael, please go ahead.
Great, I'm going to try to share my screen. Can you all see my slides? Great.
Yes.
So really, I'm going to try to provide a high-level overview of where we are with the epidemic, focusing mostly on where we are in the United States and in North Carolina, and really set the stage for the fabulous talks that will come from Randy Towns and Dr. Sine. So first, just an overview of where we are globally with epidemiology, and this comes from the Johns Hopkins Center. But unfortunately, in the last 3 months, we've seen the cumulative number of cases more than quadruple globally, and we're now fast approaching 35 million cases worldwide. In addition, we're fast approaching really a grim milestone of 1 million deaths globally. Unfortunately, the U.S. continues to lead all countries in total cumulative cases and deaths, and we surpassed 200,000 deaths in the United States earlier, or actually last week. And you can see sort of the global distribution of cases, mostly affecting the global north and increasingly South Asia. But one thing I did want to, there we go. One thing I did want to highlight about the U.S. epidemic is just the profound health inequities that we are seeing with the disproportionate disease burden among people of color and indigenous people. So this is a figure that's from NPR that shows sort of a categorization of the share of the population broken down by race and ethnicity, as well as the share of deaths and share of cases. And as you can see from the middle bars for Black Americans and Hispanic Americans, Black Americans continue to become infected and die from COVID-19 at rates that are more than 1.5 times their share of the population. Similarly, for Hispanic and Latinx persons, they face a disproportionate rate of infection in 45 states of the District of Columbia. And this disproportionate disease burden also affects Native Americans and Alaskan natives for places where data are available. So I think, as Dr. Sine mentioned earlier, it's hard to wrap our minds around such a high caseload because really behind them we get desensitized, but there are families and social and psychosocial implications of this that are just devastating. In North Carolina, we've not been spared from global and national trends. As of September 28th, there have been a total of more than 208,000 lab-confirmed cases. And you can see from this map, which is in the top left-hand corner, the per capita cases in North Carolina. So you can see in sort of the counties south and east of Chapel Hill, we've been seeing a disproportionate burden of cases. And these are communities that really UNC Healthcare and some of my colleagues have been responding materially to by providing outreach, COVID-19 testing, and other health services, working with the North Carolina Department of Health and Human Services. And unfortunately, of all the cases reported in North Carolina, 23% have been among African Americans and 34% among individuals who report being of Hispanic ethnicity. So this also reflects the same national trends in disproportionate disease burden among persons of color. Since the start of the pandemic in North Carolina, 3,400 people have died, and this is featured in the graph to your bottom right from the North Carolina Department of Health and Human Services. And African Americans have been particularly disproportionately burdened. They account for 30% of all statewide. I think one thing that has changed since March for sure, and definitely you can feel it on our clinical services and inpatient COVID service, is that I think we're starting to galvanize around sort of a understanding that's more nuanced of the pathophysiology of COVID-19 and how we can respond with treatment. So this figure sort of illustrates that there are roughly 3 stages of disease that reflect varying disease severity. As most of you know from previous talks, about of those patients who have symptomatic disease, about 80% experience mild disease, 15% severe disease, and 5% critical disease. And this appears to reflect a continuum of viral replication and a host inflammatory response that sort of progress with time. So early in the course of illness, in stage 1, we see mostly mild symptoms, mostly high-level viral loads and viral replication, and patients present with fever, dry cough, or some mild constitutional symptoms. But over time, as the host immune response starts to pick up, we see more local inflammation in the lung and the airway, causing shortness of breath and low oxygen levels in blood. We see that manifest in chest X-ray images, including on CAT scan and plain X-ray, and laboratory abnormalities. And during that stage, we've found that we can treat patients with remdesivir. That's the appropriate time to sort of offer that therapy. We can reduce the duration of severity of symptoms by about 3 days. And we see, although it bears confirmation in larger studies, perhaps a trend towards decreased mortality. As we get further along in the disease course, we get into an area where patients present with critical disease. They may be in shock, they may have hyperinflammation. And so this is when the host immune response is really out of control. And there's been a demonstrated role for a corticosteroid, which dampens that response sort of globally, called dexamethasone. So really our treatment algorithms, which have been led by the Division of Infectious Diseases, colleagues from critical care and hospital medicine, have focused on oxygen, dexamethasone, and remdesivir matching to the different stages of illness. And with that, we've really seen some positive results in the hospital. UNC has really been at the forefront of developing new therapeutics to kind of complement what we know, which is the 3 drugs that I mentioned, and have been at the front lines of examining new therapies called monoclonal antibodies. And really, monoclonal antibodies are just engineered versions of the same virus-fighting antibodies in the body that help block the virus and help block entry of the virus through the ACE2 receptor on the surface of cells lining the respiratory tract. So the monoclonal antibodies, as we're starting to think more about applying them as intervention, have application, we think, both for prevention and treatment, and that's what makes it really exciting. So if we can block viral entry, we can use monoclonal antibodies potentially as pre-exposure prophylaxis for people who are at risk of SARS-CoV-2 infection, as post-exposure prophylaxis for people known to have been exposed to the virus, as preemptive treatment for patients who have confirmed early infection but maybe have minimal or no symptoms, for treatment both in early and late disease when individuals may have fever or have complications. So we're studying at UNC the application of monoclonal antibodies really across the spectrum for prevention and treatment, and this is work being led by Mike Cohen. We also have been real leaders in the application and understanding of convalescent plasma for fighting COVID-19. So as you all know, plasma is really the liquid non-cellular component of blood, and it can be collected from patients who have recovered from COVID-19 and can be used to sort of supply antibodies to individuals who are now suffering from the disease to help block the virus. So in a way, it's like transferring immunity to a new patient. So we've been using convalescent plasma both at UNC and across the United States. There have been more than 80,000 patients who have received this treatment. We do not yet know 100% that it is evidence-based practice. We see from mostly cohort studies that there may be a trend towards reduced symptoms or a trend towards reduced mortality, but that needs bearing out in large randomized trials. And our UNC researchers are actually leading one of the most promising trials, looking to see if high levels of antibodies in plasma can produce a benefit for survival over the standard FDA recommended levels of antibodies in plasma. This has really been a multidisciplinary approach, bringing together colleagues from the lab as well as from the clinic. UNC has also really been at the front lines of vaccine development. Yesterday, I was actually in our Clinical Trials Research Center vaccinating participants in the Moderna study. And I'm sure some of you are already aware of this, but it bears repeating that sort of the pace of discovery has really been breathtaking. Usually, the pipeline of developing a vaccine can take a decade or more. I think with the real galvanized effort from academia and the Department of Health and Human Services and NIH, this has been an accelerated timeline on the order of a year or two. This is the latest information about where SARS-CoV-2 vaccine candidates lie in the development pipeline. We have about 150 vaccines that are in preclinical studies. That means not yet in human trials. 27 have passed on to phase 1 studies, so we're testing the safety and dosage of those vaccines. 2 are in sort of expanded safety trials, or 15 rather, in expanded safety trials known as phase 2 trials. And now we have 9 vaccines which are in large efficacy testing, including 2 at UNC, including the Moderna trial and the Novavax trial. We have been trying to expand access to these trials to the communities that have been historically marginalized and disproportionately affected by COVID-19. So as of last week, we had enrolled 120 participants at UNC in the Moderna trial, and 20% of those were Hispanic and 60% African American. So we are trying to address equity in our research. Finally, this is my last slide. There are a host of other research efforts which I really can't go into that you may have heard on previous Game Changer talks, but I wanted to highlight EID 2801, which is really an oral drug that shows the most promise for treating COVID-19 in an outpatient setting. This novel compound is a mutagen. It was identified by Ralph Barrick's group, and the clinical trials are being led by Billy Fisher. So that holds a lot of promise for being able to get out of the hospitals and meet patients when they have early disease, as I mentioned in my earlier slide. And then there's a number of other trials, including the active 1, 2, 3, and 4 trials being led by David Wall, Joe Iran, Cindy Gay, which are looking at a host of therapeutics, including modulators. And then Convalescent Plasma really has been a team effort at UNC, and we're national leaders in that area. That's involved colleagues both from the School of Public Health as well as from the Division of Infectious Diseases. And I just wanted to share, this picture. It takes a team effort. This is just one picture. This is a multidisciplinary response to the COVID epidemic in Lee County, which has been one of our most hard-hit counties. And this includes colleagues from the health department, from PHS, from UNC Healthcare. So really, it does take a team effort to make a more successful response. Thank you.
So, Michael, thank you for the update on that. I would encourage those of you that have questions to use the chat function, and Leslie and I will work those questions in, but a couple for Michael that were sent in ahead of time. The first one, Michael, UNC plans to reopen in the spring. How do you imagine student testing will look like at that point?
Thank you, Dr. Burks. I think that's a challenging question, and it really brings together a host of colleagues. So there's an entire testing committee that works with the university that brings expertise from our School of Medicine and the Division of Infectious Disease to kind of bear on this. And I think what we are envisioning is really driven by some modeling data from Raquel Walensky out of Mass General, which suggests that if we can increase the frequency of testing and use some of the new saliva-based testing and offer testing at regular intervals as frequently as 2 to 3 times a week or more, that we may allow individuals, including students, to test and isolate in their dorm rooms. I think we would have to make a strategy to reduce the total number of students that are allowed back to campus and cohort them, which has been done successfully in some other areas. And then we need to provide support to our students so they can quarantine safely in place in their own dorms, like we would for members of the community. And that would include providing food packages or food delivery for those individuals, and making sure that we mobilize the students themselves to kind of spread the word about the importance of doing this. So there are testing committee meetings actually this week, and hopefully there will be a plan moving forward in the coming weeks.
Okay. So, Michael, another question that people ask not infrequently is, as we age, then the outcome is really different in the older group of individuals. I say that lightly because I kind of get in that group a little bit. But if you can, for us, just kind of parse out what are the comorbid factors that play in that? Is there one major one? It's a multiplicity of them that really contribute to the increased mortality and morbidity as we get older?
Yeah, so probably the best study that's looked at this was published in Nature last month, and it took advantage of the robust data in the UK's National Health Service. So there were about 17 million different outpatient visits and records reviewed, including about 117,000 who were hospitalized. And really what emerged clearly there are the following comorbidities were driving severe COVID-19 disease and mortality. And those were age. So age was actually the largest independent risk factor for severity and death. And it appears that that accelerates over the age of 60. So it fits very much with the admission profile that we've seen at UNC Healthcare. Obesity, hypertension, chronic liver disease, and then some chronic hematologic and oncologic diseases. So recent solid tumors or liquid tumors like Cova. So in each of those appear to be acting independently, and sort of the interplay of those is very complex. But from what we can glean, it seems there's upregulation of the receptor that allows the virus to enter, and also abnormalities in the host immune response. So sometimes it just sort of lets the virus get too far out of the gate with replication, and then by the time the body responds, because of those comorbidities, the response, particularly in obesity, we're starting to see is really dysregulated and causes sort of systemic illness, including complications which include fluid on the lung or small clots in the peripheral vessels, which cause a lot of the morbidity and mortality we're seeing in the hospital.
Okay. One of the questions that's come up, Michael, on the chat function is related to what you just talked about. And the question is about the binding of the COVID-19 to the ACE2 receptor in the lung and fat cells and impact on that for obese subjects. So just a little bit more about where you were going just now.
Yeah, I think part of this may be both I think it's really kind of the downstream signaling in the immune response in individuals who are obese. And there's actually, I can share a nice article in Science from last week that kind of breaks this down, and our understanding is changing, but it looks like some of the chemicals that orchestrate the immune response, these cytokines, are not regulated properly in individuals who have chronic obesity. And some of the immune cells, the T cells that sort of are the conductors of the orchestra, they sort of operate in a disordered fashion, so they're not making a symphony. Instead, they're getting different parts of the orchestra to play at the wrong time. So I think what we need to do is think about sort of some of the therapeutics that sort of can work irrespective of individuals' comorbidities, and that's why monoclonal antibodies will promise, because they prevent binding. And then we're starting to see some work that's focusing on these anti-inflammatory drugs that are really targeted, so not just using a shotgun approach like dexamethasone, but that apply more nuanced understanding of pathophysiology of COVID to knock out a few of these dysregulated aspects of the immune response.
Okay. So then one last question for now, Michael, and we'll come back to some of the others. One of the panelists is asking about the rapid testing. You talked about the saliva-based, but talk about, in addition to saliva, the other types of rapid testing that people might read about and why it can get confusing when rapid testing means something really different for each type, and then the results are really different.
That's a great question. So the FDA has issued emergency use authorization for 2 different antigen tests. And so these are tests that are more easily deployable at the point of care and hold promise in that they can be done more easily in primary care clinics and offer a rapid result reporting, so they can be reported in about an hour. The problem with them, though, is they sacrifice sensitivity. And in public health settings, they may have an application, and we're starting to see this more as we do outreach testing, especially among individuals who are minimally symptomatic. But as a diagnostic test, if you're symptomatic or really sick from COVID-19, you want a PCR-based test that looks for the viral particles in the nasopharyngeal and in the airway. So those are the tests that we've seen mostly in our clinics and hospitals, because they really give us the tried and true answer whether someone has COVID-19 infection.
Okay, good. Thank you, Michael, and thank you for a really good update. And we'll come back to some of the other questions in a few minutes. I want to ask Crystal to talk just a little bit about the research that she's been doing here really for over a decade and a half, and then her new role in the healthcare system. So Crystal, thank you for being with us today.
Sure. Thank you, Dr. Burks. So yeah, I've been at UNC since 2008. And since I left my residency at Yale in Connecticut, after residency, I did a fellowship at Johns Hopkins. And there has been health services research, and got my MPH in cardiovascular epidemiology. So a lot of what I've been doing since I started has been health disparities research. I particularly focus on understanding the sort of social determinants of cardiovascular health and thinking about strategies to improve and to reduce disparities by race, ethnicity, and socioeconomic status. But one of the areas that I really focus on a lot and I'm passionate about is patient and family engagement and thinking about strategies to improve the care of adults with chronic illnesses, particularly by involving their family members in care. So I think of myself as sort of a sociologist in a physician's body. So I'm often thinking about social context, and most of my research is addressing social contextual factors that influence health. So I research social isolation as a risk factor and a strong determinant of health. And it's interesting, I was doing that work many years before COVID, and now it's come sharply into focus with social distancing. And I feel like every day I'm seeing articles on social isolation and its impact on health. So that's a lot of the work that I do. One of the large studies that I'm leading right now is a randomized trial in 8 primary care practices in North Carolina through UNC Physicians Network. And I'm looking at implementation of really a different approach to clinical decision making for older adults with multiple chronic conditions. And we know that that's a population that's often underrepresented in clinical trials. And so I'm really trying to create a paradigm shift in the way that we deliver care, so that the care that we deliver is really focused more around what matters to patients and their families, and not as focused on our disease-specific metrics, because those are problematic in people who have multiple conditions. And often the outcomes that we value most are not the ones that are most valued by patients. They're particularly more interested in a quality of life and their functioning and the impact of their illness on social relationships. And so I'm conducting a large study right now to see if we can change the approach that we use so that it really is driven by patients' priorities.
Good. So it's pretty amazing work Crystal's been doing for a long time. So can you talk a little bit about your new role in the healthcare system and where you hope we'll be going and what we'll be doing?
Yes, so this is really exciting. Another one of those unexpected blessings of COVID as we kind of deal with these twin pandemics of COVID-19 and I think racism and the increased emphasis on sort of the structural inequities that impact our, health and well-being of all of us, actually. Dr. Burks and the large team in the health system created this new role. And so I'm grateful that they invited me to lead this effort as the Executive Director for Health Equity. And really what we are trying to do is make our health system more equitable, more inclusive, and anti-racist. And I'll talk a little bit in my remarks about what that actually means, and really change the outcomes for our patients, and not just our patients, but also make sure that everything that we do is benefiting the communities in which we serve. And so I'm excited to lead this work. I think the health system has been very intentional about differentiating our work that's focused on diversity, equity, and inclusion as distinct from our work that's focused on health equity. And I think that though, on the one hand, the DEI, which is the short name that we use when we talk about diversity, equity, and inclusion, that's focused often on our employees, our coworkers, our culture, and the vendors that we use. And my work is really focused on our patients and our communities and addressing social determinants of health, which I'll actually also talk about. So we're in the process of undergoing a planning and a strategic planning process to get a plan together for the next 5 years. And so that is really exciting. And I'm excited about this work. I'm excited about the intentionality that is being placed on it and the commitment to the work. And I really do believe that it's going to transform not only our health system, but our beloved state of North Carolina, which is my hometown, my home state. So I'm excited.
Good. So, Crystal, there's been several questions come in. One I'd like specifically for you to think with us about. And the question is, how are our medical practices, both the public ones, the private ones, protecting patients from discrimination?
Yeah, so that is a really, that's a big question. I think that the interesting thing about discrimination is that it's a patient's experience of it. Sometimes it can be very difficult to tease out whether there's actual discrimination or not. Of course, our health system has laws and policies, written policies in place that are designed to protect our patients from discrimination. But I think the thing that we have to be attentive to is that discrimination is an experience. And so patients may have experiences of discrimination and their perception that they are being discriminated against, which can be difficult for us to tease out. But I think that what we do is to really, I think that we strive to treat our patients like we would want our own family members treated. And I think that part of it is holding ourselves accountable. I know that a lot of the divisions in the School of Medicine and the Department of Medicine are really trying to be more intentional about naming racism, naming discrimination, talking about how it affects our healthcare, pulling in the science, and making sure that our quality improvement efforts are actually backed by what we know in the science. I know my own division of general medicine, we are being very intentional about these issues and really talking about it as a full division, including our clinical and non-clinical staff. So I think that we're really, I think the first thing is awareness raising, and I think that that's being done, and then using the structures that we have in place in terms of our laws and our policies to make sure that our patients are not being discriminated against. And if they are, or if they perceive that they are, to actually invite them to, and encourage them to actually talk to us about it, and we will be accountable for making change.
Okay, Crystal, thank you. This is a question that, again, a common question for all three of you, Crystal, Michael, and Randy. But it's striking in the two maps that Michael showed, the international one and the local one, the statewide one. The international one, there are huge differences across the continents, across cultures. And then in the statewide map, like really as you look east of 95, it looks really different than it does in the Triangle and other places. And so, I mean, these are related questions, and the answer may or may not be the same in both of them. But just for Michael, maybe internationally, and Crystal, like on the state one, what issues play out and why there are really that much difference? And things that people commonly talk about are the federal government approach in different places, how different they are, the culture itself. The virus is different because of mutations. There are other reasons that people speculate on. It depends on where we come to the discussion. But just from a medical scientific standpoint, walk us through something like that and what you see with a slide like that.
You want to go first, Michael?
Sure,
we were talking about this before.
Yeah. So I can share at least my perspective from living and working in Zambia. So Zambia, as of today, has about 14,700 cases. It's a country that's a low-middle income country in Southern Africa and has a population that's about double North Carolina. And so why are those numbers different? I think the factors really are, as you might expect, they're multifactorial. But I do think there's some that are worth bearing out as we think about our sort of response, both at state and national level. One is, as I mentioned to you, there were national guidelines and a national policy for Zambia before the first case entered the country. So there was robust response. Second, there was public health infrastructure for response. So through much of the generosity of the American people through the President's Emergency Plan for AIDS Relief. So the U.S. has led in the global fight against HIV, and over the last 17 years, that has created public health infrastructure in many countries. So that was mobilized for COVID-19. Thirdly, is the demographics of the country. So many places have younger populations or have populations without the same chronic diseases that we see in the U.S. And fourth, I think, has to do with some of the social determinants and structural determinants that Dr. Sine was talking about. So in Zambia, health is a human right. Anyone can get access to it. You may not have the right to get or access to high-cost procedures, but basic prevention and primary care is there. And two is there's no legacy of racism in Zambia. You know, there's the legacy of colonialism, which has been dealt with, but some of those factors, the structural and social determinant factors, have not been as, I think, prominent in some countries where there is some more basic access to healthcare and access to equity among the most, or access to health equity among the most marginalized populations. So that's my perspective in a case comparison between Zambia and the U.S., but certainly there are abroad very different responses. So, you know, in Singapore or Vietnam, there's been a top-down federal approach for public health measures that we know work, like universal masking, contact tracing, testing scale-up, quarantine and isolation that also help. So let me stop there.
Okay, thank you, Michael. Crystal, additional thoughts?
Yeah, I was going to say, I think Michael touched on a lot of what I think why we see some of the disparities in North Carolina, but I'll point out a couple of them. I mean, I think that certainly when we look at differences in North Carolina by sort of regions of the state, the resources that are available to folks is very different, and that includes healthcare, their own personal resources in terms of their income and the number of people who are sort of in poverty or the working poor. I mean, I think that's very different than the Triangle area, and so, you know, access to care and high quality care, including testing, has been very different. I also think that, you know, there is certainly some of the social features, some of the social factors, for example, with the Latinx population in terms of living in multi-generational housing, for example. So if you have multiple generations living in the same house, their risk, if one person acquires the COVID-19, it's more likely that it's going to spread. We have more of those individuals who are living in poverty, who are not having the privilege to be able to social distance, having to go out and still look for jobs, even during the midst of the pandemic. So I do think it's a lot of the social determinants of health that are big drivers, and the ability to access care. I think certainly earlier on, we saw a lot of misconceptions in terms of COVID-related information. Blacks, for example, it was a common thing that, oh, well, Blacks can't get this because of the way some of the things have been handled in the media, and, you know, a lot of that population felt that they were not at risk for the infection. So a lot of misinformation, I think, that certainly contributed. But again, I think a lot of it is social drivers, and I do some work with a colleague in Paris, looking at some of the epidemiological trends in Senegal, which is also one of the African countries. And again, we see some very stark differences in terms of how the pandemic was handled. They immediately went into lockdown and had some very effective lockdown measures. So I think that was pretty different. Some of the comorbidities, the prevalence and the distribution of comorbidities was very different for a lot of those countries than it is here. So some of the things that Michael already alluded to, I think, is why we see some of the difference across continents.
Okay, thank you, Crystal and Michael. Next, I want to ask Randy to talk about a group of people that she's been leading in her mobile testing and done some amazing things in the last few months. So Randy.
Yes, so thank you. I have the pleasure of highlighting some of the solutions. So Crystal, well, Dr. Sine and Dr. Ayers have done a great job of outlining some of the problems that we've seen in the way COVID is affecting different populations. And I'm going to talk about one of the solutions we've had as a healthcare system. So to re-emphasize the problem, we've seen that COVID-19 has had a disproportionate impact on Black and Latinx communities specifically. We also know that due to socioeconomic disparity, there are specific areas of the triangle that were particularly vulnerable to COVID-19. And then we also know that these groups of patients, these populations, they have a general mistrust of healthcare for various historical reasons. And when healthcare systems try to deploy solutions in times of crises, they're concerned that they won't be credible and that they won't be culturally appropriate. So we as a healthcare system, we were challenged to design a testing program tailored to these specific communities that address those challenges. So the way that we did that is we deployed mobile testing. So we leveraged one of our rec heart and vascular vans that weren't being utilized. We bought some tents, we got some donated tables and chairs, and we rounded up some staff that at the beginning of the pandemic, because we had closed a lot of our clinics and weren't delivering service in the same way, we leveraged those staff to deliver this testing near communities. So really core aspects of our program was, one, going to the community, really trying to switch the power dynamic where generally patients come to us. They come to where the doctor is in the white coat, you come into the room and the doctor asks you what's going on with you, to us really going to their neighborhood, going to their churches, going to their community centers, and allowing them to come to us and allowing us to come to them. And we didn't have on white coats. We, of course, had on PPE, but we generally had on T-shirts and hats because it was hot outside, and tennis shoes. And really just creating a very, it just changed the power dynamic of the way we delivered testing. And something else that was really important, before we did anything, we talked to community leaders. So understanding that there's a history of mistrust between healthcare providers and the Black and Latinx communities, we wanted to make sure that everything we did, we understood what the community wanted, what was important to them, what did they need. When we're thinking about hours, what hours would patients be most likely to come? Did we need to do it in the morning? Did we need to do it in the evening? Were weekends something that they would be interested in? Where should we go? What are the trusted places in the community where even if you don't trust UNC, you may trust your church. So the fact that UNC is partnering with your church, you're more willing to come get tested. So how could we leverage some of those relationships? And then most importantly, promotion. As Dr. Sine alluded to, there was so much misinformation out in the public. So how could we leverage sources that were seen as credible? Maybe it wasn't UNC posting something to their social media. Maybe it was the YMCA posting something. Maybe it was El Centro, which is a Hispanic advocacy organization, posting something. So how could we leverage those channels to really make sure that we were doing targeted promotion to the right populations, and also understanding that there are a lot of disparities that these patients are facing. It just wouldn't be enough to provide testing alone. So how could we do the most good and really treat the whole person? So then we're going to go to the next slide. So we launched a mobile testing service on May 7th. We focused in Southeast Raleigh, but we have gone some other places. Dr. Harris explained a little bit before that we were in Hillsborough, and we focused all of our testing in churches. We went to schools, public and charter. We went to community centers, and we also did the parking lots outside of free clinics because they serve uninsured, underinsured populations and a large point of the time, minority populations. Our target volume was 100 patients per day, and we often did testing 3 days per week. As I mentioned before, community members were a huge advocate of 3-day testing. They didn't think that people would be interested in testing on Monday, and they didn't think that people would be interested in testing on Friday. So they felt it was the best to just do right in the middle of the week. And then all of our promotion went through those community leaders and grassroots organizations. So whether it was sending it through the YMCA, sending it through our community health worker who posted to their neighborhood, neighborhood next door, or churches who then circulated it around their team. It was really important that we made sure that the promotion got to these populations specifically. We know that early in the pandemic, there were limited testing capacity. So we wanted to make sure that we were here to meet this one need. We wanted to make sure that we were targeting all of our education and promotion to that one population. So when I spoke to treating the whole patient, we offered a number of services beyond testing. So one of them, the most important in my opinion, is education. So one, how is COVID transmitted? But also going beyond that to say, how do you disinfect your house if you test positive? How do you educate your child about what COVID is? There were some amazing coloring books that explain COVID to kids, so we would hand those out. How do you if you live in a multi-generational home and you don't have a lot of space to separate, how do you do that effectively? If your job is forcing you to come to work or you'll be fired, how can we make sure that you do that in a safe way? So really understanding that these individuals may not have the luxuries to quarantine at home, to work from home. How can we educate them on the ways to keep themselves safe as well as everyone else? We also provided access to social support resources. So in the pandemic, we've seen that food insecurity increase. We've seen that transportation needs increase. We've seen that financial assistance, those needs increase. So how could we be intermediary and provide coordination to patients who needed those? So we were aware of a lot of food drives. So if patients came to us and they needed food, that we would be able to direct them where to go. One patient story that I love to share is that there was a mother who visited our mobile testing site. She had twins who were about 6 months old, who had just tested positive, and she was extremely sick. We knew that it was she was 99% likely to have COVID. She didn't have any food at home. She did not have any formula. She did not have any Tylenol, and her babies had fevers, and she just didn't know what to do. She didn't have any money to go to the grocery store. She had an appointment with WIC, but it was a couple of days away. So we had community health workers who were there, who were able to coordinate with various community resources across the Southeast Raleigh area to make sure that by the end of the day, someone was doing a non-contact delivery to make sure that she had the food and the Tylenol and the diapers and just the basic necessities that you need as a parent to care for your children, even if they weren't sick. So we were being able to provide those social support resources was so important and something we were so glad to be able to help. And that is just one case of many cases where really being able to meet immediate needs. Additionally, we were able to provide access to virtual behavioral health support. So understanding that pandemic increased the levels of anxiety and stress for a lot of people. And we also know that in these populations, they often don't use behavioral health resources. So we were able to provide a resource that was free of charge and that they could access virtually just to talk about what was going on with them. We provided cloth face coverings for day-to-day use. Early in the pandemic, we've seen that a lot of individuals from minority communities didn't know why they needed a mask. They also didn't have the funds to buy one, and they also didn't like the style of masks that were on the market. So we had some very cool masks donated from various sources that we were able to provide, whether it had a Superman on it or it had SpongeBob on it for kids. It made the face coverings a little more acceptable to the population so that they were willing to wear them, which we've seen as a major win. We also provided comprehensive nurse follow-up for patients who tested positive. So understanding a lot of these patients did not have primary care homes. If they were to be tested at a CVS, they would get their test result and then really be left to deal with that on their own and not know where to seek care and not know what they needed to do if something about their symptoms changed. So we were able to enroll them in our comprehensive nurse follow-up, and if they tested positive, they were followed up for 2 weeks. So if there was a change in their symptoms, somebody was calling them every day that they could talk through it. Our nurses were trained that if the patient doesn't have insurance, where can you send them? If they needed to see a primary care provider, what are the resources in the community? Or if they needed food, how can we get them that? So that was also another great service. And then also guidance to further primary care if needed. So understanding that there are needs. Some patients came and our providers were literally wanting to care for them in that moment, wanted to diagnose them or treat their high blood pressure or their diabetes, but just understanding that they needed needs beyond that what we can meet. How can we guide them to make sure they have primary care that fit their financial status? And just to note at the bottom, all of this was possible through the UNC Health Foundation and individuals like you who gave to the COVID-19 Response Fund. We did not charge patients who were not insured. So we are very grateful for your support, which allows us to do these types of innovative interventions. These are some pictures of our test site. You can see Dr. Irsay at the top left. He was one of our providers. So we swabbed patients in the car. We had providers who educated patients from the car. All of our COVID samples were kept on coolers. We had an amazing team. Everyone who came out was extremely passionate about this work. We would have providers who would spend 10 and 15 minutes with the patient, making sure they understood, which I felt was a true benefit. If you had not talked to a provider at any point during the pandemic, you could trust that if you came to our mobile testing site, you were going to be given that attention as a person. They were going to ask you how you were doing. They were going to ask you what you needed. It wasn't all about swabbing you and getting you through the door. It was making sure that you understood what it meant to be healthy during this time, and that we could help you. Even if it was only in this 20 minutes, we were going to give you the most we could in this 20 minutes, which has been just amazing. And we've had such great feedback from patients who really appreciated the service we were able to provide. And the next slide is about our impact. So over the course, since we started in May, we've tested almost 2,500 patients, which I think is amazing when you think about we were only operating 3 days a week. All of this was happening outside of a van or a bus, and we would drive to different locations, and this was all really word of mouth. We didn't do any mass promotion. It was just we sent it through a community partner, and they sent it somewhere, and they sent it somewhere, and from that, 2,500 patients were tested. We're very happy that a very large majority, more than 70%, were of that Black and Latinx community. So we were getting to the patients that we wanted to get to, and 53% were uninsured. And then of the patients tested, we've seen a 15-cent positive rate, which, as Dr. Irsay and Dr. Sinead mentioned earlier, a higher positive rate in this population, a large majority of those being Latinx and uninsured. Another note, a lot of those were Spanish speaking, so we had to have a lot of interpretation services on site, which also was a great service to be able to provide. Additionally, we provided 208 social resources, whether it be food, medication, financial assistance, and we provided over 1,400 homemade cloth masks, again, that were all donated and that we've been able to use. And then the chart to the right, I wanted to show because it really speaks to the change in volume and also the change in positive rate. So the blue bars that you'll see will be our volumes per week over the life of this program. They started low and then they got really, really high. There were some days where we were seeing 150 patients a day. And then you'll see now in August, the volumes have really decreased. And there's a lot of different reasons or things that we assume to be the reasons, being expanded testing in other areas, just testing fatigue, people just being tired of the conversation around COVID, not really understanding, not seeing value in testing. So we have seen a decrease in our testing volume, but as you can see, the orange line, we're still seeing a relatively high positive rate. Just the other day, I want to say we tested 10 patients and 3 of them were positive. So we're still seeing that it's still being transmitted in these communities. And the gray line that you'll see is the Wake County positive rate. So you'll even see that our testing compared to Wake County generally has a higher positive rate.
So Randy, it's amazing work that y'all done in the last few months to be able to come together as a group. I honestly got more emails from not only the community, but really people that you work with and say that they've worked here for 5 years or decades, and this is the most meaningful work that they've ever participated in. So thank you. The striking thing as you talk, one, your enthusiasm, which is great, and two, like what you ended up on, the positivity rate that people read about and talk about, that's here. That's like in the triangle. This isn't like someplace far off. It's a real thing. It's right here that we have the opportunity to make differences in. So thank you for what you've done. And just to be respectful of people's time, I apologize that we couldn't get to all the many good questions that are there. So hopefully we'll have other times to be able to answer those questions. I want to thank Randy, Michael, and Crystal for what they do, who they are, and the amazing work that they've done, not only recently, but for a long time here at UNC. So Leslie, I'll turn it back over to you as we finish.
Sure. Thank you, Dr. Burks, and thank you, Dr. Sinead and Erthe and Randy. We really enjoyed your presentations today. And yes, as Dr. Burks said, we will carry your questions forward over to the 6th episode of Game Changers. If we didn't get to them today, we will certainly do our best to do so next time. I wanted to just close out on a couple of resources that are available to you. The first one being our UNC Health main link for our COVID-related information. So a lot of the things that we've talked about today are posted there on that website. And then I also just wanted to say, if you are touched or moved by anything that you heard today and you would like to make a financial contribution to help us, there's information here about our COVID-19 response fund, and we'd love to have your support. You got to see a wonderful example of your dollars in action with the work that Randy's doing with the COVID mobile testing unit. And then lastly, I just want to say Dr. Sine is presenting grand rounds tomorrow. So if you want to hear even more about the work that she's doing in health equity, tomorrow from 12 to 1, she will be conducting grand rounds, and we can get that information to you if you'd like to join in and listen in. Again, thank you so much for your time today. We appreciate you being with us, and we will look forward to seeing you at the next session, which will take place on Tuesday, October the 13th. Thanks again for being here.
Thank you.
Thank you.
Okay, thank you all so much for joining us for this second part of our time together. This is our opportunity to really spend a little bit more quality time with Dr. Sine and Dr. Erithe and Randy. And so, Dr. Burks, I'll turn it to you and then open up the floor for even more questions of this group.
Okay, so please, if you have more questions, either just raise your hand and start talking or go to the chat function. I'm going to lead with one question that's a combination of things that people ask earlier on the chat function. One, is there a minimum exposure level that creates the disease? And the second part of it is, what's the optimal time for testing as you think about the different scenarios? So Michael, maybe you start on that.
That's a great question. So a lot of folks have spent a lot of time thinking about what is that minimum inoculum, and I think it's more than just the disease, it's the host pathogen interaction. So the inoculum is certainly less for individuals who are immunocompromised or have major comorbidities and have, for example, more ACE receptors in their respiratory airways. And then your second question, Dr. Burke, sorry, I missed.
Like the optimal time for testing, because there's a bunch of different scenarios. I'm exposed or not having symptoms, I'm having symptoms. What do you tell people for about testing part?
So for the most part, it takes about 48 hours to kind of create the viral titers that are sufficiently high enough that we can detect them on the most sensitive test, which we have, which is this nasopharynx, they call it the brain tickle PCR-based test. So usually after 48 hours following exposure, there's a high enough level that we can detect that using the most sensitive tests. And then that sort of can persist out for weeks after an exposure, whether or not someone sort of is symptomatic or not. As long as they sort of establish infection in sort of the airways, that's when we can detect it. So if you've had an exposure and you're high risk, if you went to go test that same day, it's not likely you will be positive. But if you were to wait 72 hours, 48 to 72 hours, that would be the starting point for being able to detect it. Certainly some people have strong innate immune responses, and a lot, like young people, have very robust immune responses, so they may clear that after a couple of days after an exposure, not establish infection, and have a negative test. So it really depends on the interplay between the virus and the host.
So one of the follow-up questions people often ask about are viral titers in the asymptomatic group, the mildly symptomatic, all the way to the severe individuals.
Sure.
What's the differences in them? Or is that a useful predictor of those categories?
So as far as we can tell right now, we don't think that the titers themselves are as predictive of the outcomes. We've seen, I was mentioning Billy Fisher's outpatient study of the EID 2801 compound. For the most part, we're seeing people with minimal symptoms or actually who are, very mild disease with titers in the billions per ml. So incredibly high levels of virus in the respiratory epithelium and in the airway. But that doesn't necessarily predict progression to disease. It's more of that dance with the host and sort of predisposing factors that we talked about earlier. We do think that we can start to get some predictors of the host immune response along with that titer that may sort of set a trajectory. But a lot of the damage that we're seeing, frankly, is with the body's ability to control replication of the virus and limit it to the upper airways and not cause a disorganized systemic immune response. That's where we really see, in that figure I showed, as that gets worse in the later stages of the disease, that's when we see multi-organ dysfunction and most of the complications we find in the hospital.
Okay, so I get the prerogative to ask my questions first. So please raise your hand, start talking, and ask Michael, Crystal, Randy, anything. Tom.
Yes, I think Dr. Hersey might be the appropriate person to answer this one as well. You mentioned earlier the prospect of the University, Chapel Hill, reopening or inviting people back into campus. The new roadmap has not been announced. And in full disclosure, I have a grandson who will have to be making a decision whether to come back or not. So I had three concerns there that you can comment on. One is the density of the residence halls. And the second one is the availability of places for those exposed or who test positive to quarantine or recover. And then the third is the issue that you raised about using testing.
Yeah, I think those are great questions. So the first is, I think with the original roadmap, there was an effort to try to decongest the campus. And we saw that a lot of the cases we saw on campus were actually imported from off-campus housing and off-campus sort of social venues. So I think that needs to be addressed fundamentally. Like, we're not a silo. We live in basically a community and solidarity with the surroundings. So we have to think about how we control the influx of people in and out of campus. That's one. Two is we want to make sure that all dorm rooms are single dorm rooms only, and that we have to probably institute more frequent self-testing of individuals to monitor for early infection. We probably need to extend that to people that are coming from off campus and have a set of rules about that. That is, there are a lot of people that have more gray hairs than I do who are thinking about that nonstop, and I think are our brightest minds in infectious diseases. And so that is definitely a concern. The second is about, we did try to model our approach after successful approaches in Vietnam and in China about having sort of an exposed dorm so people could quarantine after exposure, and then an isolation dorm. Individuals who test positive can be alone in a room. And I think we would like to continue that, but I think we just need to reduce the numbers, allow people to do self-testing, ideally with the saliva-based test, and then support the students who are positive isolating, helping them get sort of free food delivery to their dorm room and sort of create an enabling environment so they can participate in school and not feel totally isolated. In the hospital, simple things like having an iPad on wheels so we can video conference with family members has made a huge difference in sort of the morale of patients. And I think we need to kind of think along that way as well to make the students buy into it. It's a great question.
Okay, thank you. Thank you, Michael. Bob, Carol, questions that y'all might have?
I'd like to thank you for Randy Townsend, Dr. Sinay, and also Dr. Hersey, but I identify most as a former AHEC librarian and daughter of a pediatrician, with everything Dr. Randy Towns said, and I wish I weren't old so that I could be right on the lines helping her. But I have two questions. Would it be possible, because COVID will get solved, that's going to go away, and there'll be some big other thing we're all concerned about, but I would like to see in every UNC Foundation communication, the athletic communications, all of them, some news about health equity, because I view this as the biggest health problem in North Carolina. So I'd like just an update every month or however often the alumni bulletin, anything comes up, some information on what's happening. I mean, what Randy Towns said today was fabulous. So could that be worked into UNC publications, please?
Go ahead, Leslie, go ahead. You're smiling.
No, for sure. I mean, I think, you're going to continue to see us highlight not only their work, but the things that are coming down the pike here. And so, yes, you make a really good point, Carol. We absolutely will be focusing more on that in our publications.
So others, questions?
I was just going to add, Carol, thank you for your interest. We are definitely, I'm a part of Dr. Shanae's new team, and we're doing a lot about how do we make sure that as we're developing our plans, that they're visible to our partners and our stakeholders, and we're developing a website. So there's going to be a lot more coming out of our department to make sure that the community is aware of what we're doing, and that also we're able to get feedback from you around what is important to you and what do you feel we can focus on. So a lot more to come from health equity specifically, in addition to what we'll push through the foundation.
And I'll just add to that we hope that you will also hold us accountable. Part of why we really, I really want to be transparent about what we're doing and what we're planning is because I want to be held accountable. I want us to be held accountable for making sure that this is not just a moment, but really that this is a transformative movement that we continue. And even if our, who's in our leadership of our country changes, even if that happens or whatever happens, we want this issue to be central, because health equity really crosses everything that we do. We pride ourselves at UNC on providing high quality care, and I think that inherent in that is care that is equitable, because I don't believe that we can really provide the highest quality care possible if our care is not equitable.
I have one more small quick question. Could Dr. Burks work with the other 3 medical centers and then all of the AHECs so that this was a statewide buy-in to something that's really important? I would love to see that.
So, Carol, thank you for a really good suggestion. And certainly there are a lot of things that Crystal and Randy and others are doing here that are going in that direction. The governor's appointed a task force to do some of that, but just even down below that, having had discussions with the people in Durham, the people in Raleigh, we'll certainly take that to heart, so thank you. So others have questions for our panelists? Richard?
Tom, Dr. Vinroot?
Yeah, hey, I'm so sorry I got on a little late. I had a meeting this morning and I apologize. I'm interested to know, and y'all may have breached this, but are any of y'all, and Dr. Burks, you're included in this, do we know of how, obviously there's so much press out there and as to how these schools are doing, and there was some report that said, there were just thousands of positivities at about 4 or 5 schools. Do we know, are y'all aware of any bad outcomes or hospitalizations or even fatalities that have occurred at all of these college universities, especially the ones that are getting all this press, us being one of them, obviously? I'm just interested to hear, obviously there's a lot of press about how much positivity and how poorly this has been handled at a lot of schools, but are the folks having bad outcomes? Because I haven't heard of anything at this point, and I'd be interested to know how whether it be at State or Duke or East Carolina or even some of the other HBCs, just if we're having bad outcomes with these folks that have come back to school. Are y'all familiar with that?
So Michael, go ahead.
Thanks for that, Dr. Benru. That's actually something that we track. We have sort of daily infectious disease team meetings on COVID-19, and as we were mobilizing the testing response in Chapel Hill, the Respiratory Diagnostic Center and others, that was one thing we really paid attention to. And so we actually disaggregate testing by students, and we've tested well over 1,000, and then we tracked some of the hospitalizations, and we have not had, I think we have had one hospitalization of a UNC student and a successful discharge. I've not heard of any sort of mortality or any serious adverse outcome for a student infection, to the best of my knowledge, at Chapel Hill, since we've been following that really over the past several months.
Well, that's good to know. And I think that this article focused on Notre Dame, Chapel Hill, a couple other schools, and it said, I think the article actually said there had been no hospitalizations. So that would be consistent with you all having one. So that's obviously a positive.
So others, questions for
Tom, did you have
panelists?
your question?
Leslie, repeat what you said. It got lost.
Oh, sure. I just said, Tom, did you have another question? I saw you come off mute.
Well, not really, except that I've heard that in the university system that it was probably UNC, East Carolina, and NC State that told people to go home and couldn't handle the volume, but that a number of the schools, including the HBUCs, have stayed open, have not closed campuses. And I'm not sure that that's true, but that came from somebody that works at the Board of Governors. That and the fact that Duke, I think, is still open, even though they had only freshmen and sophomores. So I'm just wondering, are we learning anything from the schools that are being successful, or we just have too many students and too many kids living off campus to be able to compare ourselves?
So Michael, you want to comment, or any of you, and then I have a couple of comments.
Yeah, I'll just briefly, this is not a specific area of focus, but I do think there's a couple things we're probably learning. One is, I think cohorting different classes makes sense. So I think clearly Harvard has done sort of only seniors and freshmen on campus. There's similar schools that have done that. Two, the frequency of testing matters. There's pretty good modeling data that suggests, you have to be able to test and get the result fast enough to be able to isolate. And if you can't, if the turnaround time is really much more than 24 hours, that's sort of done that effort. So we have to improve that. And three, for the students that are allowed on campus, we have to do a better job of sort of isolation and tracking movement on and off campus, limiting off campus like congregation, and then spilling into the campus community. So I think those are three big picture lessons that I think we're learning from some of the data, but let me turn over to Dr. Burke.
A couple of thoughts there. One, part of the reason in the roadmap here that the actions that were taken was not necessarily the volume, but the rate of positivity, how quickly that the population that came back went from none to a number of them. That rate was really different here than in other places. The second piece, just to think as you hear the news reports, is when people talk about being open or not open, it's an ambiguous term that's really difficult to know what they really mean. Like the number of classes at Duke and here that are really in person probably isn't a whole lot different, honestly. But I mean, they have students there, they have some freshmen, some sophomores, but not all of them. They, just by the nature of, that's like how the school is anyway. Their freshmen are on one campus, the sophomores on another. Typically their juniors and seniors are off campus. That didn't really change that culture. And the number of, if I'm a freshman at Duke right now or Notre Dame, the number of in-person classes I have is probably not a lot different than Chapel Hill. So that open or not open can be left to a lot of interpretation. So as you look at it differently, the next piece of it is that the acceptance of both the local community and the statewide community in what's going on. And I'll use Tuscaloosa as an example. The number of people that are positive in Tuscaloosa is way more than here. But they, for whatever reason, big picture culture, society, this is not critical at all. It's just, it's different than here. Their acceptance of what happened and what they want to do is just different culturally. And so that, again, takes into account like the different responses, different places. And then I guess the third thing I'd add is, just like you saw the map of the world and the map of North Carolina, then the prevalence of disease in that particular location has an impact on that discussion. You know, whether a school is small or big, the control of a private versus a public, the prevalence in that community impacts, again, the actions that are taken. So the prevalence in the triangle in April and May is different than it is right now. As I look at my wall map, the prevalence in Johnston County and Nash County today is way different than it was even 6 weeks ago. And again, those all play a part in how colleges open or don't open, and then their responses.
Thank
May
you.
I ask Dr. Sine one question, please?
Please go ahead, Carol.
I was very interested in the 8 primary care practices you were studying. Were they pediatric or internist, and do you feel you're going to be able to take things that you learn from these practices and apply them, sort of going out in circles and make it larger and larger from Manteo to Murphy?
Yeah, thank you for that question, Carol. So they are all primarily going to be family medicine. So they will see children, they will be family medicine and internal medicine, but our study is only focused on older adults, 65 and older. But I'm an implementation scientist. So that means that in addition to understanding what makes an intervention effective on health outcomes or clinical outcomes, I'm interested in studying and evaluating how do we actually get it done in practice? How do we make it integrate within the workflow of the practices? So I think that part of our study and those outcomes that we're assessing for that part will help us to understand whether this can be spread throughout, or what our study needs to, how it needs to look differently when people do it, whether they're in a practice in Manteo or a practice in Murphy. So we will study that and look at how is the workflow affected by what we're asking people to do.
Thank you.
Mm-hmm.
Other questions from the group? John, any questions that you might have? Okay. So, Randy, I was going to come back to you when the discussion about the mobile testing unit and setup, and people went from like, we're not ready yet to we're going to go do it, happened really rapidly. And so in that time frame, you had an expectation of what would happen, and then something happened. What was it the same, or was it different than what you anticipated would happen?
Yeah, that's a great question. I will say it was 2 weeks from the idea was presented to, okay, we have a bus and we're at Martin Street Baptist Church in Southeast Raleigh.
Yeah.
It definitely was not my expectations. One, how fast it came together. I was completely shocked. Generally in healthcare, doing anything for free, which we technically cannot say free, just has a lot of legal barriers and regulations. So I thought it was going to take a lot longer to work out all those kinks. And then also, so often you hear that strategies like this are delivered, but then the people never come. So we didn't really go into it with the idea of if we're there, people are going to come. We were really intentional of how do we make sure we build it in a way that's encouraging. And we really didn't know. Our first day was a lot of just working through the technical kinks of trying to have a clinic on wheels and the network and the supplies and all the things that you don't think about, the luxuries of being in a building. I think the first day our tents flew away. Having to reach for some weather. And then the second day, our testing started at 1, and by 12:30, there were 50 people in line. And that was a complete shock. And every day for probably a month, people were waiting for us, and we often had to close because we just could not keep up with the demand. And working 8 hours straight forcing our team members to take breaks. The time ended up being a barrier. There just wasn't enough time to get through all the patients. And there was I never would have imagined that would have been the situation, or even the kindness of the patients. So many patients were just genuinely happy that we were there. Even if they stood in line, some patients waited for hours because 150 patients get there before you open. It's just going to take time to get through them. They waited for hours, and they were just as kind the moment they arrived from the moment they left. Many of them just cried, just appreciating that someone cared for them. So we were expecting people to be apprehensive, and of course people were afraid, but just the genuine joy that someone cared enough to deliver something to their community and to allow them the time to talk to a provider and allow them the time to ask questions was honestly beyond anything I could have imagined.
Okay. I can remember after the first day that y'all did this, then the text I got, and then what happened then in the next few days is the positivity rate for that community was so much different that it was just overwhelming for a while.
Yeah, there was definitely one day where I want to say we had a 40% positivity rate, and it was, wow, we just wanted to test around the clock. I literally had to tell our provider, we have to leave. Our team can't be here. We'll come back tomorrow. It was a point where we were like, there's so much need. We just feel like we can't meet the need. And then it just kept going up. We had patients who came in cabs and Ubers. And they were we knew when we seen them that they were likely positive, and they just needed someone to tell them what they needed to do. So yes, it was, we were really shocked once we started seeing the 40 and 30% positive rates.
So I know we're nearing the end of the half hour, and I want to make sure that if there are other questions that we have time for it. So any other questions, even if you ask one, please ask another one. Okay, I'll just, in the way of closing, first thank Randy and Michael and Crystal for being on with us today. It's one of the privileges and opportunities that I have in the role here is to work with individuals like this that are truly amazing. I don't get to see them enough. I seldomly see many of them, but every time that I have the opportunity to do something like this or other things to hear more in depth about what they're doing, it's just overwhelming because they are amazing people and amazing things that they're doing both here and abroad for changing people's lives. So with that, I want to thank you for your support, being on this additional time, and turn it back over to Leslie.
I'll just close by saying thank you. You've gotten to see one great team. We've got an incredible team and talent, and I'm glad you all stayed behind and joined us for a few extra questions, and we'll look forward to seeing you next time.
So thank you.
All right.
Thank you, everyone.
Bye.
Thank y'all very much.
Okay.